when we first arrived at Madwaleni, and this may be a problem that many of you face arriving in a new facility, is that you meet with lots of different doctors who have slightly different approaches to things. And one of those things that we realized was acute gastro, and it was quite a tricky and semi-dangerous dynamic for different doctors handing over kids with gastro with different kind of, using different techniques for rehydration. And so one of the first things that we tried to do was get everyone on the same page. And I hope this approach that I have to share with you tonight helps you to do that. And I'm not sure how you're feeling, if you feel like this picture describes your mind with kids, or if you feel like you're all over it, but I hope I've got something helpful to share with you. So there we go. So I borrowed this clip. This is a clip I did for another conference I was at in Durban. And this is just to show you kind of where I am. We're at a rural hospital on the East Coast, on the wild coast of the Eastern Cape. And this is what rural looks like for us. But with this, I just want to make the point that rural might look different for different people. And this is just us. And you may be sitting in a rural setting or not a rural setting. Yeah, I think it's important to know where you are, because that's how you're going to apply kind of guidelines to your setting. So we're going to talk through 4 parts in this kind of conversation this evening. I'll set the scene of gastro in South Africa. I'm going to present to you an approach that I find very helpful, and it's kind of based on 4 questions to ask yourself when you're faced with a kid with gastro. Then I'll share some pearls and pitfalls, and finally we'll make some room for questions and discussion. So hopefully I won't blabber on too long. I'm going to be talking quite fast, so that's breaking a rule that I as a presenter shouldn't be speaking quite too fast. But there's a lot of information to share, but fear not. There are some added bits and pieces to help you kind of remember and to engage with this stuff. So afterwards in the resource pack, I'm going to share our 2-page approach that will complement existing resources, I hope. And I'll share a piece of stationery with you to help you with your kids and managing them in the wards. And there's a pre-test quiz. If you haven't got a chance to do it, fear not, it's definitely not a prerequisite, and it might still be helpful to do it afterwards. If you find yourself still a bit confused, it might help you kind of hone in on some of the things we spoke about in this talk. Right, so let's start by setting the scene. And maybe I'll just start by saying that gastro is a big deal. So if you look at causes of death in children under 5 in South Africa, diarrheal diseases are always right up there on top of the leading causes. But it's interesting, I was scanning through data that I could find, and when you look at kind of the more rural districts in South Africa, diarrheal diseases peak as #1 quite consistently. And if you look at more urban settings, then lower respiratory tract infections and other things like preterm birth complications peak up. The Western Cape, interestingly, definitely don't have diarrheal diseases right up there. And that's probably a reflection of their infrastructure and what else is going on there. So diarrhea is a big deal. The second thing I want to point you to is a little QR code at the bottom. I've scattered a few resources through the talk. So all you have to do, and I hope this works, is open up your phone, open up the camera app on your phone, point it at that QR code, and it should take you to the website where you can find each of these resources. So this is for the District Health Barometer. And if you don't know it, it's a great resource for looking at the indicators that are available out there. It's a great summary. They publish them every few years. This is the latest one I could find, the 2019-2020. And in there, you'll find data on South Africa, different provinces, and on your district as well. So this is for Amatola district. And you can see here that for children under 5, male and female, diarrheal diseases are right on the top of our problem list, causing mortality in children. And this is where I am in Amatola district. Now, the second point I want to make, I'm just struggling with slide progression, is this. Having said and having spoken about that data, it's important to realize that especially in rural areas, we may be missing a lot of the deaths that happen at home. So this was an interesting study where they looked at 3,700 kids under 5 who died between 2000 and 2015 at 2 rural sites in KZN. And what they found was quite striking. So only 41% of those children died in a facility, and the rest died at home. So if you look at the light blue at the bottom, I'll see if I can get a pointer going. There you go. So if you can see my pointer, or just cast your eyes to the bottom of that kind of graph, and you'll see the light blue are the kids who died in facilities, and the rest of the kids died at home, which I think is quite a marked point and probably reflects a lot of rural areas. The second point from the study that I want to share is kind of the light green versus the dark green. Of the kids who died at home, the light green are the kids who, in their final illness, presented to a healthcare facility. So at some point with the final illness, whether it was gastro or pneumonia, they presented to a facility and were sent home and then died at home. So bear that in mind as we talk about gastro, and as you see kids, are they going to be able to get back to the hospital? Do they know what to come back for? Yeah, because this is quite striking. That study is under the QR code there. Now, we're going to be talking a lot about the management of these kids in our facilities, but if we do management right, we're probably saving lives in the order of ones and tens of children. But if we can prevent gastro, we will probably save in the order of hundreds and thousands of children's lives. And the kind of backbone of prevention for diarrhea are immunizations, clean water, and breastfeeding. By immunizations, I mean especially the rotavirus vaccine, introduced in South Africa in 2009. It's had a great impact, and I think we've decreased deaths by around 40% from diarrhea with that vaccine, which is great. In terms of clean water, the kind of standard that we're aiming for is piped clean water into someone's home. And, when we're thinking about indicators, that's the standard that we're hoping for. Everything else that's not reliable or not quite clean, or a JoJo tank outside, that doesn't count. And finally, breastfeeding. Breastfeeding is so important. But we're not doing too well. In terms of immunizations, according to the District Health Barometer for the Eastern Cape, only 68% of our kids are fully immunized by the age of 1. In terms of clean water, NGO did a house-to-house survey locally around our hospital between 2013 and 2015. And I don't think they found any houses that attained the standard of clean water. Even for me here living at Madwaleni, I kind of only reached the standard last year when I piped water from our JoJo tank into our house, because our hospital water supply is kind of sporadic and not 100% clean. And finally, breastfeeding. Our breastfeeding rates, this is counted by looking at kids who present at 14 weeks and if they're still exclusively breastfeeding. And sorry, when I talk about breastfeeding, I mean, if you really want to make a difference, you need 6 months of exclusive breastfeeding, followed by up to 2 years and beyond of breastfeeding with complementary feeds. And that's in kids with HIV and not living with HIV. So we're not doing great. Only 43% of our kids are still breastfeeding. And these are difficult things to change. But my encouragement to you would be to start small and see what a difference you can make in different ways. And a lot of that starts by figuring out what's happening in your setting and how you can kind of influence those. But it's not easy. Now, moving on to how best to manage these children. With a few guidelines out there, how do we pick which one to use? Especially if you've been at a big tertiary center with a very clear guideline for your hospital, and you're now in a rural setting where there's no guideline, how do you know which one to use? And I just want to remind you of these levels of evidence. It's a pyramid with systematic reviews right there at the top, critically appraised topics, which include kind of evidence syntheses and guidelines kind of below that, and expert opinion right at the bottom. So don't be fooled by experts. And just kind of remember this as we're trying to figure out how to best manage these children who present with diarrhea. Now, just a little, something helpful I thought you might benefit from is, I just want to share my go-to resources. So I'm going to punt the standard treatment guidelines now, and I'll punt them again later, and I'll punt them again at the end. But if you're looking for guidelines, the methodology in developing the standard treatment guidelines in South Africa is incredibly robust, and they're hugely helpful guidelines. So I'm talking about the adult hospital level guidelines, the pediatric hospital level guidelines, and the primary healthcare guidelines. And I want to tell you to use those as your Bible for managing gastro and whatever else you encounter in your facilities. They're immensely helpful. And here's a QR code that'll take you to the Knowledge Hub website, where you can download here the PEDS hospital standard treatment guidelines, and you'll find the others there as well. The second very helpful resource is Up to Date, which is a great synthesis of latest evidence. And if you're working in a rural setting, you can apply for a free kind of access to UpToDate. So if you scan that QR code, it'll take you to a website where you fill in a little questionnaire, and within a few weeks, they will send you your login details. And I would definitely recommend you look at that. The standard treatment guidelines are sometimes a bit sparse on explanation and detail, and that's where UpToDate is hugely helpful. And finally, for our approach, we kind of amalgamated resources that I mentioned above, as well as the WHO resources. The emergency triage assessment and treatment initially came out with a lot of new evidence on how to manage these kids, and we'll talk about that now. And in their 2016 updates, they gave a few more helpful details. So I'll mention those as we go. And finally, I'll present you with our guideline. So it's a 2-page document. And what I hope it is a simplified approach to complement the pediatric standard treatment guidelines. This approach was taught to me first by a pediatrician where I was doing my ComServe in Kimberley, Dr. Peter Jooster. And in a genius way, he took a complicated guideline and simplified it down into these 4 questions. And I find these 4 questions so helpful to ask when I'm treating these kids, and so helpful to use to teach others on how to manage these kids. And it's been great because that was back in 2013 based on the WHO guidelines that came out initially. And it's been really nice to see the PEDS standard treatment guidelines from 2017 kind of catch up to these guidelines. So they complement each other really well at the moment, which is great. So the 4 questions are: how severely dehydrated is this kid? Which fluid are you going to use? How much fluid to use, and how fast to give that fluid? So it's a lot of detail, but like I said, this is the guideline that we'll share with you afterwards. And so through the rest of this talk, I'm going to spend the next 20 minutes or so going through each section, sharing the details here. If you're feeling overwhelmed by the details, fear not. I mean, I'm very available for questions, and the quiz will help, and having this resources will hopefully help as well. And remember, this is only kind of an approach to complement the standard treatment guidelines. So please go back and have a look at that chapter in the standard treatment guidelines on acute diarrhea, and that'll fill out any details that are still lacking. And there are a few minor differences between our approach and the standard treatment guidelines. Have a look at those. If you've got questions, you're welcome to message me as well. Okay, so let's start with the first question at the kind of top of the document, and that's: how severely dehydrated is this kid? And the first point I want to make here is that I find it really helpful to clearly distinguish between dehydration and shock. Shock is kind of intravascular stuff, and dehydration is all extravascular and intracellular stuff. And if you've done different courses in PEDS, like the APLS or the PELS, it's like a UK-based and American-based courses on, treating kids in emergencies. They have slightly different approaches to shock, and some of them kind of classify shock according to cause, like hypovolemic shock or distributive shock. But the WHO in their most recent kind of updates have simplified it just to say, if you have these 3 signs, call this kid shocked and start there. And those 3 signs are cool peripheries versus central. So feel the hands and feet and compare it to the central chest. Check for a reduced capillary refill of more than 3 seconds. And check for weak, fast pulses. So I've seen studies use a heart rate of more than 160, but WHO just says weak, fast pulses. And if you have all 3 of these, it's shock. If you have less than 3 of these, kind of call it impaired circulation. And I find it helpful to think of shock as a spectrum, these kids getting kind of worse and worse. And I've kept decreased level of consciousness in there, because by the time you get decreased level of consciousness, a kid is pretty far on the extremis of that spectrum, and a kid is really circling the drain. And that's a helpful phrase from one of those courses that I'll repeat later. So that's shock. And shock is different to dehydration. You may have heard of classifying dehydration into kind of 5% and 10%. WHO have updated that thinking, acknowledging that those aren't exactly accurate, because there's actually quite a wide spectrum of percentage fluid loss. And what they've gone with is actually just calling them, calling these categories no dehydration, or some dehydration, or severe dehydration. And at the bottom, under the asterisks, I've said that signs like sunken fontanelle and tears or moist mucous membranes may help if unclear. But, excuse me, so the WHO have also simplified your assessment into looking for 4 signs. Okay, what's the condition of the kid like? Is the kid alert, irritable, or lethargic? What are the eyes like? Are they normal or sunken? Are they thirsty? Do they drink normally, or are they thirsty, or do they actually drink poorly? And what is the skin pinch like? Is it normal, or 1 to 2 seconds, or more than 2 seconds? And If you have 2 or more of those signs, you pop into that relevant category. And what's helpful to realize is that if you have a child who's irritable and thirsty, but normal skin pinch and normal eyes, they actually have some dehydration, and it's helpful to rehydrate them. And we'll talk about how next. Oh, before I carry on, I'm going to share our first poll. So I think I can share from here. I'm going to ask you a question. So 9-month-old child presents with a 1-day history of vomiting and diarrhea. The child is irritable, thirsty, eyes are sunken, and the skin pinch is slow. Peripheries are warm, capillary refill time is 1 second, and radial pulses are strong. So what would your assessment of this child be? So if you can all see it, I can see some answers coming through. And I'll give another 30 seconds. Okay, I'll give another 10 seconds. Okay, so we've got most answers now. Okay, so seems like most people went with some dehydration and some people went with severe dehydration. So let's go through quickly. First of all, the child is not shocked. Peripheries are warm, capillary refill time is fine, and radial pulses are strong. So when we think about dehydration, the child is irritable, which puts the kid in a moderate category for me. The child is thirsty, which puts it moderate. Eyes are sunken, which could be either moderate or severe. And I've said skin pinch is slow. So I haven't quite classified what that means. So fair enough, if you've said that the child, if you've imagined more than 2 seconds, you could have popped the kid in severe dehydration, or kind of less than 2 seconds but slow would have put this kid in moderate dehydration. So yeah, so well done. And I hope that helps a little bit. I've said this kid is moderately dehydrated, but fair enough, I didn't classify exactly how slow the skin pinch is. Okay, so we're gonna move on from there. Okay. We're gonna go on to the next question, and which fluid to use. So the first thing to say here is that a lot of guidelines still prefer IV dehydration, but that's kind of old thinking. WHO in their updates really are pushing to use oral rehydration, and their buzzword is rapid oral dehydration. They think it's safer, you can rehydrate these kids quicker. And so their kind of mantra is for dehydration, use oral, and for shock, only use IV fluids. And what I want to introduce to you here is this idea of a ladder. So if you have 3 different ways of rehydrating a kid, you've got oral rehydration, you've got nasogastric rehydration, and then you've got IV rehydration. And your first step is to kind of pick which route you want to use. So your go-to would kind of be oral, but if you have doubts about that, you can step up. And if you have doubts about that, you can step up. And if you start on one rung in the ladder and you review the kid and he's not doing well, you've got space to step up as well. And yeah, based on which route you choose will kind of dictate what fluid to use. So if you start with oral or nasogastric rehydration, you're pretty much going to use Orsol or like oral rehydration solution, which could come in a prepackaged thing, or it could be homemade sugar salt solution, which we use sometimes if we run out of the kind of pre-packaged oral rehydration solutions. So kind of the idea is to start with an oral trial, or to use nasogastric tube if you have doubtful cooperation from the caregiver or the child, if there's lots of vomiting, if there's massive output, or if you're just seeing a poor effect of oral. And then to think about IV. So when to use IV and which fluid to use. Sorry, I had a helpful pointer, so I'll get to this. We've spoken about that, and we're going to talk about IV. So this is the kind of most wordy of the 4 questions. So bear with me as we go through this, sorry. But let's talk about IV fluids now. So when should you use IV and which fluid to use? So IV, we have to use IV for boluses when a kid is shocked, or for rehydration in some circumstances. Okay, so that idea of shock versus rehydration. So boluses, you use boluses to treat shock and rehydration to rehydrate a dehydrated kid. And you can use them in the following circumstances. So if your first two rungs of the ladder, your oral or nasogastric tube has failed, maybe the kid is vomiting a lot, or they're huge losses, or there's consistently poor intake, you can use IV. It's probably a good idea. Some people say post-shock. There's this idea of as you reperfuse a child, they will preferentially reperfuse their brain and their heart and their kidneys, and the mesenteric circulation will take a little bit longer to reperfuse. And so if you give them oral fluids, that might not be well absorbed for the first little bit. So there's half a recommendation to maybe use IV rehydration initially for the first 4 to 6 hours before you add oral. And then to really think about kids like who are very fluid sensitive. So kids with SAM, severe acute malnutrition, try and avoid IV in these kids unless they're shocked. So they do really badly with IV fluids because they get fluid overloaded really quickly. Cool. I'm going to move on to, boluses for shock. So which fluid should you use? I've highlighted and underlined Ringer's lactate here over normal saline, and that's what the WHO prefers. And that, in my mind, just makes a lot more sense because, there's nothing normal about normal saline. But you'll see in the standard treatment guidelines, for some reason, they've still picked normal saline, and I'm not sure why. It's got really high sodium and chloride, kind of higher than what we have, normally, and Ringer's lactate has a bit of potassium in, and it's got a bit of lactate in, which helps with an acidosis. So Ringer's for me makes a lot of sense, but I don't think there are any good randomized control trials to kind of really help us with which one to choose. So it's really preference. I've just made a note here under that to avoid glucose and IV boluses for shocked patients. So only use glucose containing fluids if a child is hypoglycemic. And then here's a little formula to remember. You can use 5 to 10 moles per kilo of D10%, so 10% dextrose, or 2 to 4% of 25% dextrose. So you can take a 50% dextrose, dilute it with sterile water to make a half kind of strength of that and give 2 to 4 moles per kilo. So if you have a kid who's hypoglycemic, give that and then reassess the glucose in 10 minutes. Okay, so those are boluses for shock. And then IV rehydration options. So half DD is probably the easiest one to go for. The standard treatment guideline says it's safe up to 10 mils per kilo per hour. Just remember, it's got quite a high glucose and a relatively low sodium content. So it's probably a good idea to monitor blood sugar in these kids that you're rehydrating IV. If that's not available, you can use Ringer's lactate or normal saline, and you can add a bit of extra glucose and potassium to that, and there's a little formula. But half DD, if you've got it, is probably the easiest solution to use. And in terms of IV rehydration infusion rate, so there used to be old calculations to think about maintenance requirements, ongoing losses, insensible losses, and you used to work out a complicated formula over 24 hours. But an easy rate to remember is 5 to 10 moles per kilo per hour IV. So start there. Remember that 5 moles per kilo per hour is 120 moles per kilo per day, which is roughly about maintenance for a kid under 1 year. So if you imagine, if you're starting at 5, you're only just reaching maintenance for an infant. So anything above 5 is rehydrating a kid. So I would usually start at about 10 moles per kilo per hour and monitor the kid closely for any signs of overload. So when I say closely, probably within an hour or 2 hourly review. And the helpful things to look for are respiratory rate, heart rate, a change in the size of the liver, and an S3 gallop. So what I do is I definitely take baseline respiratory rate and heart rate with these kids. I sometimes draw a mark with a pen where I feel the liver. And when I review this kid in 2 hours, I'll make notes of how those have changed. Right, so a lot of information, sorry. I'm gonna pop up another poll to kind of help you process. And this is actually something I haven't mentioned, but it's in the standard treatment guidelines. And let's put that out there. So a 6-month-old child presents with acute diarrhea and hypervolemic shock. So this kid is shocked. You struggle to gain IV access. After how long should you abandon attempts and try an intraosseous access? So what I'm trying to tease out here is this idea of circling, a child circling the drain again. And it's a really helpful teaching that comes from APLS. And there's this idea that a kid who presents to you with shock is circling the drain, and you have very little time to stop them from falling down that drain. So if you have a kid with shock in front of you, you got to manage that shock immediately, and you don't walk away from the child until the shock is resolved. And sometimes I find myself getting caught out faffing a bit, trying to get up an IV line, and time goes really quickly in these situations. And so this kind of guidance and standard treatment guidelines is really helpful. So it's been about a minute. I'm going to end the poll there. And the answer is 5 minutes. So most of you got to that. And so remember this, give yourself no more than 5 minutes to get an IV line up on a kid who presents shocked, because they're circling the drain, and you have to manage that shock immediately. Otherwise, they will go down that drain. Cool. Okay. Let's see. Right, so we have spoken about which fluid to use. And you'll kind of see at the side next to each section is the question. So we're going to move on to the third section, and that is how much fluid to use. So let's zoom in there. So it's a little bit different for shock and dehydration. For shock, the guidance is to use 20 mils per kilo boluses up to 3 times in kids, but there are a few exceptions. So if a kid presents shocked, the volume is 20 mils per kilo. You can do up to 3 boluses, but there's some exceptions. And in those exceptions, the idea is that they're a little bit more fluid sensitive. And so you want to go with slightly smaller boluses of 10 mils per kg. And you'll see this idea of recurring numbers through this guideline, 20s and 10s. And I hope this helps you remember stuff when you're going through this approach with a kid in front of you. So 20 mils per kilo boluses or 10 mils per kilo boluses. The exceptions are small kids under 2 months old, kids with hyponatremia, kids with severe malnutrition, and cardiac or renal patients. And the idea is that once you start giving a bolus, you should reassess after every bolus. So I check heart rate and respiratory rate, check the liver, and check the response. So I'll check pulses and I'll check the radial pulse before and after bolus. And if there's no response and no overload, I'll give another bolus. In a field where there's often very little evidence, we've actually got pretty good evidence that a lot of fluid is quite bad for kids who present with shock from other causes. So there's this trial called the FEAST trial, where they looked at kids in kind of East Africa mostly. And these were kids who were shocked, who presented not with diarrhea, so not with hypovolemic shock, but they presented with kind of septic shock and malaria. And in that study, they showed that if you give a kid like that too much fluid, they'd actually do worse. So our learning then transposed into these kids with gastro is, so firstly, we assume that they're hypovolemic shock, which is different to septic shock and kind of kids with malaria who are anemic. But these kids should respond to 3 boluses if they've got hypovolemia. And if they don't respond, it probably means that there's another underlying cause for their shock. And that's a little red flag for you to stop and to take a different route. And that usually means needing inotropes. So if you've got a kid with gastro presenting, you give 3 boluses, they respond really nicely, then that's great. You're going to move on to rehydration. But if they don't respond, think about septic shock or some other causes of shock and kind of stop there. Don't keep flogging the kid with fluids because they're going to do badly. And you change tack and get some inotropes going and discuss this kid really quickly. In terms of inotropes, just a reminder that adrenaline is probably a great option for most kinds of shocks. It's probably like the second best option in each of the different kinds of shock. And so it's a great option for us. It's freely available. And it's fine to give adrenaline through a peripheral IV access in these kids for short-term adrenaline, like we would do while we're stabilizing a kid before we transfer. Right. And then we're going to talk about how to rehydrate a kid. And that depends on how dehydrated they are, whether they're not dehydrated, they have some dehydration or severe dehydration. And the deficits are probably about, if you don't have any dehydration, imagine the kid losing about 10 mils per kilo of their body mass with each stool or vomit. So that's how much that's their deficit that you need to replace after every loose stool or vomit. Their deficit, if they're moderately dehydrated, is about 80 mils per kilo. It's kind of about 8%. And for severe dehydration, it's probably about 120 mils per kilo, so about 12%. And that's the kind of deficit that you're trying to correct. Okay, so I'm going to post our third poll at this point. Okay, this is just to remind you. And you might, if you've done the quiz, the pre-test quiz, you will recognize these. These are just little samples from the pre-test quiz. But here we go. So how many boluses would you give in a shocked, probably a kid with hypovolemic shock child, before changing to inotropes and considering other causes of shock, like septic or distributive shock? So the two parts of this, you're thinking about a normal kid or a fluid sensitive kid, which you give 3 boluses of 20 moles per kilo and 4 boluses of 10 moles per kilo. Would you give 2 boluses of 40 moles per kilo and 2 boluses of 10 moles per kilo in fluid sensitive kids, or 4 boluses of 20 moles per kilo in normal kids and 2 boluses of 10 moles per kilo in fluid sensitive kids? So this looks a little bit different to the table I showed you just now, and this is straight out of the standard treatment guidelines. Another 10 seconds or so. Okay, great. So most of you got to exactly what we were hoping for, and that is, so 3 boluses of 20 moles per kilo to treat shock in a kind of normal kid. And I said 3 boluses. Standard treatment guidelines says you can give up to 4 boluses of 10 moles per kilo in a fluid sensitive kid. Great, well done. Cool. Now, moving on to our last question, almost there. How fast to give fluid to that child? So the buzzword is rapid oral rehydration. And in most kids, you can rehydrate them at 20 moles per kilo per hour, except in some exceptions where you should rehydrate them at a slower rate at 10 moles per kilo per hour. So here are those two numbers again, 20 and 10. And the exceptions are the same exceptions as we were considering when we were thinking about how to bolus kids with shock. Kids less than 2 months old, hyponatremia kids, severe malnutrition, and cardiac or renal patients. Just a note on hyponatremia, I haven't covered that here. I haven't covered severe acidosis here either, but the standard treatment guidelines have good approaches to those. So look there for guidelines on those. Now, if you go back to the deficit we were thinking about, in a kid with some or moderate dehydration, their deficit's about 80 moles per kilo. And if you are giving them 20 moles per kilo per hour, you'll replace that deficit over 4 hours. And if you've got a kid with severe dehydration, their deficit's 120. So rehydrating them at 20 moles per kilo per hour will correct that deficit over 6 hours, because 20 times 6 is 120. So it's like an easy way to remember what you're gunning for and kind of how to correct that deficit. And with exceptions, you replacing the same deficit except more slowly. So 10 moles per kilo per hour over 8 hours multiplied together, that gives you the 80 moles per kilo deficit you're trying to get to. And for severe dehydration, 10 times 12 hours gets you 120 moles per kilo deficit. For IV infusions, if you think of how fast to give that fluid kind of PALS and APLS talk about 5 to 15 minutes each bolus. Just to remember to not walk away. It's very tempting to leave a kid to finish a bolus and come back and check, but my rule of thumb is to get a kid out of shock before you walk away. So I give those boluses pretty much with big syringes while I'm standing there. And sometimes if I've got an infusion pump, I'll set that infusion pump really fast and let that infuse those boluses to free my hands up, which is very helpful. Finally, for rehydration, we mentioned it before, how fast to give IV fluid for rehydration, about 5 to 10 moles per kilo per hour, as we mentioned above. Cool. I'm going to launch the last poll. Okay, so I'll give you a minute to answer this, and the answer should hopefully be right here under your nose. A 10-month-old child with SAM presents to you with some or moderate dehydration. You decide to rehydrate by rapid oral rehydration. What's the appropriate rate? Is it 5 moles per kilo per hour for 24 hours, 10 for 8 hours, 20 for 4 hours, or 40 for 2 hours? I'll give another 15 seconds or so. If you can't see the answer, it should be right there. And it's just a way to kind of reinforce these numbers in your brain. I'll give you another 10 seconds. Okay, I'm going to end the poll there. I'll share the results. And most of you got there. Just to remember that rapid oral rehydration is fast. It's 20 mils per kilo per hour. You're replacing a deficit of about 80 mils per kilo in a kid with some or moderate dehydration. But kids who are fluid sensitive, like kids with severe acute malnutrition, like this kid in the question, should go a bit slower. So you're wanting to go for 10 mils per kilo per hour over 8 hours to replace that deficit. Great, and the majority of you got there, so well done. Cool. So moving on. So that's our approach. Those are the 4 questions to ask yourself. It's a lot of detail. It's a lot of stuff to tease out, and I'm going very quickly, but I hope together with the standard treatment guidelines and the quizzes, you will kind of get the hang of it eventually. And this guideline is meant to be printed up and meant to be opened up on your phone and up on the wall to help remind you. Kind of getting on to our last little bit is talking about pearls and pitfalls. And I want to show you just the bottom of the second page there. And we'll talk about the next steps once you've recognized dehydration. The first thing I want you to really remember is to start rehydration then and there. It's so easy to get busy with your notes or to get busy with other patients nurses are asking you about in casualty. But before you know it, time goes by and a kid is sitting there without any fluid on board. So once you identify a kid with dehydration, start rehydration immediately. And it's really important to reassess the kid in 2 to 4 hours. So I'd say a kid with no dehydration or moderate dehydration, I'd usually get going and check in 4 hours time. But a kid with severe dehydration, I'd definitely check within 2 hours. And then there's an idea of once you initiate rehydration, you're going to go and follow this kid up in about 4 hours. When you check the kid, start afresh with your reassessment. So decide, is this kid shocked or dehydrated? And is this kid now well hydrated, or is there some dehydration, or is there severe dehydration? And decide if this kid is doing one of 3 things. Is the child worsening, is red? Is the child showing some improvements? Maybe they've gone from severe to moderate dehydration, or is there complete improvement and this kid is completely well rehydrated? If the kid is worsening and you have started with oral rehydration, that means that kid has failed oral rehydration. And that might be because of vomits or big losses or poor cooperation. And something to talk about is who is going to be rehydrating that child. And in our setting, our nurses are busy and the doctors are busy. So what we try and do is make sure that the caregivers are on board, and we teach the caregivers to rehydrate the kids. We'll show you our stationery afterwards, but what we then ask is that nurses check up on the caregiver every half an hour to make sure that they are giving boluses to those kids. In the standard treatment guidelines, what they do is they work out a rate per hour and they divide that rate into 15 minutes kind of intervals, and they tell a caregiver to please give, say the kid needs 100 mils an hour, they'll say, please, mom, can you give this child 25 mils every 15 minutes? We find that a little bit tricky, so we aim for half hour kind of little kind of intervals, and we'll tell a mom if she needs to give 100 mils over an hour, we'll please ask her to check her phone and every half an hour give 50 mils, which is 5 of these 10 mil syringes. And then we'll ask a nurse to come and check with her every half an hour and to sign off on the stationery if the mom has given that. Right, so that's a little aside on the practicalities of it. But if a child has failed oral rehydration, we'll step up to the next rung in the ladder. If we started with oral, we'll step up to nasogastric. If the child has failed nasogastric, we'll step up to IV. The last thing that I haven't shared is this idea of nasogastric actually having 2 options. So sometimes we put a nasogastric tube in a child to rehydrate a child, but you could give rehydration in boluses with a syringe to that nasogastric tube, or you could set up a continuous nasogastric infusion, which is amazing. So very often, for instance, if I have a kid with severe dehydration, I'll set up a continuous infusion of nasogastric oral rehydration solution through that nasogastric tube. So what I do is I take a 1 liter bag of whatever, and I cut a slit in the top and I pour out whatever IV fluid was there, and I fill that with oral rehydration solution. And then I connect an IV line through an infusion pump and connect that to the nasogastric tube. The really important thing here is that anyone passing by could mistaken that IV line with oral rehydration solution in connected to nasogastric tube. If that comes out for some reason, someone could think it might be an IV line and infuse that oral rehydration solution in an IV way. So figure out how to put in as many stopgaps and safety measures you can to prevent that from happening. I put a piece of tape along the tip. Some of our other IV sets were specifically for nasogastric infusions, so they didn't work on IV sets. And so just make sure that you put safety features in to make sure that no one connects that to an IV line by mistake. But getting a nasogastric tube, a continuous infusion going is amazing. It just ensures that that fluid goes in. It takes away the kind of the kind of human error factor from a caregiver who's busy or distracted. And that constant infusion is great. And very often kids vomiting will do really well with these constant infusions. But the trick will be to be checking them frequently. So hold that constant nasogastric and continuous nasogastric infusion up your sleeve, as a little ace up your sleeve for kids who you're a little bit worried about. Right, so you could check a kid and they are worsening, or there could be some improvements. And what you do then is you just start afresh and you reassess the kid and figure out how dehydrated they are, and then reinstitute your next 4 hours of management according to that, start afresh. And if they're completely well rehydrated, you just continue with 10 mils per kilo rehydration solution after every loose stool or vomit. And just a little note at the bottom there is to remember that severe dehydration probably warrants 6 hours of close monitoring, even after they're rehydrating, because they can slip back into severe dehydration quite quickly. The next kind of pills is admissions. Who needs bloods? Probably check like electrolytes if a kid is moderately or severely dehydrated. And severely dehydrated kids or shock kids probably could do well with a blood gas. A venous blood gas is absolutely fine. Who needs empiric potassium supplements? They all do. Just to be aware of hyperkalemia, a lot of these kids will be hyperkalemic, and hyperkalemia can lead to an ileus, and that messes with your oral rehydration. So be aware of an ileus. We give potassium empirically at about 3 millimoles per kilo per day, or if the potassium ends up coming back quite low, we double that to about 6 millimoles per kilo per day. We usually give this orally because we can give quite a lot quite safely. And in the guideline, in the little document PDF that I'll share with you, I've made a little calculator to help you figure out what kind of how much potassium to give based on what you've got. So at times our pharmacy have KCl kind of suspension made from a powder, and that's quite helpful. The syrup has about 6.7 millimoles per 5 mils of fluid. You don't have that. The slow K tablets are great, except you can't really crush them because they slow release potassium. And sometimes we use the IV potassium chloride, and we give that orally if we've got nothing else. But figuring out the millimoles and the moles is a little bit complicated, so you'll be able to click on that link and hopefully it'll take you to an Excel document or a Google Sheets document to help you work out what you need. So try that out or message me if you're still confused. Zinc reduces severity, duration, and relapse of gastro. So all these kids should get 10 to 14 days. If the kid is less than 10 kgs, give 10 milligrams daily, and more than 10 kgs gets 20 milligrams daily. Don't forget zinc. And then try start feeds early. So try keep breastfeeding if the kid is breastfeeding, or start other feeds as soon as the child tolerates feeds. And then antibiotics. In an era of antimicrobial stewardship and disastrous kind of resistance and this like looming problem of antimicrobial resistance, please don't give antibiotics unnecessarily. You really only need to give antibiotics to kids who are under 2 months old because they've got a high risk for developing gram-negative sepsis, for bloody diarrhea, for severe malnutrition, or if other infections are suspected. The standard treatment guidelines has a great section on which antibiotics to use for each of those. And so there's a link there as well that you'll be able to click on in the PDF that gets shared with you to take you to that chapter and the antibiotic selection, antibiotic section. So only give antibiotics to these kids if necessary. I should probably include shock as another reason to give antibiotics because you just don't know what the underlying cause is. Okay, and who to discharge from casualty. So remember that study I spoke about right in the beginning. Many kids who die have actually presented at some point to a healthcare facility, and don't let this happen to the kid in front of you. So in our setting where patients struggle to get back because of a lack of infrastructure and all sorts of things, only consider discharge if all of these requirements are met. And this is very specific to our context, so decide if this applies to your context. But we say in our context, only if there's no dehydration, or maybe kids with some dehydration who get rehydrated successfully. So we give them a 4-hour oral trial in casualty. And so we'll only send them home if they're completely rehydrated and there's no vomiting at all. If there's any vomiting in those 4 hours, we'll kind of default to admitting them rather overnight. There has to be an absence of massive fluid output. So what I mean by that is like worryingly frequent or big watery stool. great maternal or caregiver cooperation and education on home sugar salt solution, reasonable means to get back to the hospital, and no other comorbidities. And only then will we think about discharge from casualty. Okay, so that's our 2-pager, and I hope it makes a bit of sense, and I hope it's helpful. And it's been quite a long slog through that. This is our little piece of stationery. So every child who gets admitted with gastro and is being rehydrated, we fill this sheet out. You'll see on kind of screen left there, if we pick IV or nasogastric infusion, we'll ask the person to tick which one, and we'll include the rate and the volume to be infused. We'll include a start time and an end time. On the right, if you go with nasogastric boluses or oral boluses, we'll pick which, and we write the times that they should get. So we, say it's 8 in the morning, I'll write 8 o'clock, 8:30, 9 o'clock, 9:30, 10 o'clock, all the way down to however many they need. And the nurse will need to come and sign every half an hour to say how much oral or rehydration solution was given. And I will write there how much should be given every 30 minutes. And finally, in the bottom screen left, you'll see all children need careful review. So we'll make sure the admitting doctor writes a time that this child needs review, 2 o'clock or in 2 hours or 4 hours, who will review the child, if you've handed over the child to that person, and what your name is, and kind of sign there. And the really important point here is, if you're a doctor working in casualty, admitting a child like this to the ward, and the child needs to be reviewed in the ward, figure out who's going to review that child, speak to the ward doctor, and make sure that doctor knows when that the child is there and when they need to be reviewed. Because we've had kids die, and when they have, it's because kind of this chain of handover has broken. So handing over and carefully reviewing kids is really, really important. And this is my last slide. Last kind of few pearls and pitfalls to remember. Beware of ileus because of hyperkalemia. It happens sometimes. And if you get that, you probably need to give IV rehydration and IV potassium. Beware of kids circling the drain. Respond quickly. They're spinning round and round, and catch them before they go down that drain. Beware of accidental delays. Don't get caught making notes before you get a kid some orsol and you get them rehydrating. Give them some orsol, get the caregiver to start immediately, and then go, finish the rest of the exam, put up an IV line, or, finish your notes or whatever else. And beware of small babies with big losses. If you imagine that in their gut, their little capillaries are, 1 or 2 cells away from their guts, and a few big stools can pull fluid straight from their intravascular space, and a small baby can get shocked with 1 or 2 big stools. So beware of small babies with big losses. Next point is get caregivers involved, and they need to be on board, and beware the caregiver who's distracted or not involved, and take that into account when you figure out how to rehydrate. Think about the just in case IV line. Sometimes I'll start oral rehydration on a kid with moderate dehydration who's vomiting a bit. If you come back and review that kid in 2 or 4 hours and they suddenly have gone backwards, it's going to be really hard to step up to IV if you can't get an IV line up then. So definitely in kids with severe dehydration, even if I start oral or nasogastric rehydration, I'll put up an IV line just in case for later. And in some kids with moderate dehydration, if they are vomiting a lot, I'll put up an IV line just in case. And you can always pull that IV line out after 4 hours if they're doing better, but it has saved me and has made the difference between life and death in a few kids for me. Finally, I've punted them before, I'll punt them again. The standard treatment guidelines are a great resource, so use them. Don't be afraid of them. And then finally, regular reviews save children's lives. And please, please remember that. If you're worried, please check that kid in 2 hours, and even hourly if you are really worried about a shock kid who's just come out of shock. Right, and that's where I'm going to stop. I'll kind of open up for questions. You'll find my number here and my email address here. So please feel free to WhatsApp or email me, even if you're watching this later. I'm not so good after hours, but I'll try to respond during hours. And yeah, I'm sorry I've taken so long. So a bit of time for questions, but I'm definitely open for questions going forward as well. Cool, thanks.
Thank you very much, John D. That's definitely a call to action. And actually, you can see that all the work you've done at Madwaleni is almost the end of a QIP project in your own right, and a best practice intervention that we really hope you guys can go back and implement at your own hospitals. And we've got a hand up. We'll start with that with Dr. Mativa. Dr. Mativa, would you please unmute and just ask your question?
Okay. Excuse me. I've got a question and a comment. I see in the flow of your talk, you do not actually mention urine output at all or palpating for a bladder when you're checking for fluid responsiveness. you talk about the liver size. I would include that because that's a good sign to show if you're getting fluid responsiveness. The irritability, the lack of urine output would be indications of organ hypoperfusion. I'm also glad that you did not touch on blood pressure in these children because the signs that you're picking up, the tachycardia, the cold peripheries, are actually a physiological response that the child is trying to put out to compensate for the insult, the hyperglycemia as well, because that's how they try and increase their cardiac output by increasing their catecholamine output. So blood pressure is very unreliable in pediatric patients as a measure of trying to see where they are at in terms of their fluid status. And as you said, it's very difficult to peg them as to whether they're in shock or just behind on fluids, but it's actually a continuum. Dehydration is a step on its way to shock if unattended. I think my question is, do we actually teach the caregivers how to prepare the homemade salt and sugar solution? Because that is where it should start, even before they come to a healthcare center. And one can actually give that child, that baby, even a teaspoon at a time of that solution. I guess I was talking and maybe a few questions in there. I'm going to stop there.
No, thank you, Dr. Matiba. I really appreciate that. And I'm very aware that with any guideline, there are gaps, and urine output is definitely something I didn't mention in my guideline. It comes out quite strongly in the standard treatment guidelines though. So definitely a really good point, especially these kids post-shock. We often put a catheter in and connect the catheter to an empty 200 ml fluid bag as a really helpful way of collecting and monitoring urine output. And that's a really good point. Thank you. Sorry, I can't remember your other points now, but yes, that continuum of dehydration into shock, I find it very helpful to separate the two, and the WHO have done a great job of kind of just like putting their neck on a block and, you know, putting shock onto those three signs. I find very helpful for most practitioners to then know confidently that this child is shocked and to manage from there. I can't remember your last point, but I feel like it was a good one. But thank you for your comments. I really appreciate that.
Thanks, JD. In the chat, there's a question from Dr. Johnson around the recommendation for when to call a resus to state that the patient has passed, especially if the child has come in alive. Can you do what's similar in adults, pupils fixed dilated, no papillary reflex, no central peripheral pulse, etc.?
Yeah, that's really hard. Yeah, so when to call the resus? I guess anecdotally, kids bounce back a little bit more readily than adults. So I've had far more children attaining ROSC, so return of spontaneous circulation, than adults. But generally after 20 to 30 minutes, if I haven't seen a response, that means no respirations, no heart rate in a child, I will call a resus there. So having that number somewhere between 20 and 30 minutes is probably quite helpful. And to remember that to declare a child kind of as passed, you need to satisfy all those things. They need to be warm. You need to have corrected all the things that you can correct. And only then do you kind of get to that stage of calling a resus once you've got nothing left to correct in terms of H's and T's. I'm not sure if that's a helpful number, and I welcome any other comments.
Thank you. And then Dr. Hartwig is asking, just want to find out where you get the ready-made sorrel, because it takes a long time to make from scratch.
Yeah, I don't know. I'm actually not involved in the procurement process of that, but I can definitely find out. And I remember Dr. Bativa's other points about educating, on this note, about educating caregivers around oral or sugar salt solution at home. And if you remember this, this is my way of teaching caregivers. So my one finger here is for 1 liter fluid. The little half a finger here is for half a spoon of salt. And then the 8 remaining fingers are for the 8 spoons of sugar. And that's an easy way for me to teach caregivers and to point them to their Road to Health books, just to show them that the recipe for that is in there and science for dehydration is in there as well. it's a great way for educating caregivers using that Road to Health book that they can go home with and remember as well. So sorry, actually, I'm not sure actually where we get the ready-made stuff from.
And then we've got a question about intraosseous lines. What you don't, you can perhaps give a couple of comments of, you know, if you don't have the drills and all the fancy gear.
That's a good question.
And we'll actually, we will post some videos, some Pearl videos on that. There will be a video on how to do an intraosseous line in a rural, but if you want to know that.
Yeah, so we don't have the drills, we don't have the fancy IO sets. Our go-to is to use a yellow 20 gauge spinal needle. So it's the short spinal needle. It's yellow, so it's a bit thicker than a normal black spinal needle. And I find those really helpful. They're a bit stiffer in my hand, a bit bigger for my hand to hold on to, and they've got a stellette, which is quite helpful. When I don't have those, I usually use a little combination of a pink needle. I can't remember the gauge. I think it's about an 18 gauge with a green IV cannula through that as a stellette. So you take your cannula, you remove the plastic kind of sleeve. So you just use the metal stellette and you put that into a pink needle. It's a bit more clunky. It kind of moves a bit more, but at least you've got something a bit bigger to hold in your hand and got a bit of a stellette there. And so those are kind of my first and second choice in the absence of any fancy tools. I hope that helps.
Yeah, thank you very much. I think it's a huge topic. And as you said, there's some things you couldn't even really touch on, like acidosis and etc. So this is not the be all and end all of what you need to know around dehydration. I think it's just to get your appetites weighted. And we will definitely be sending out information as well to read and look at. And I would really encourage you in terms of those printouts. This is the, you know, there's a few things that's worthwhile having printed out and on your wall in your casualty setting, and this is certainly one of them. I don't see any other hands, and there's nothing else in the chat. So thank you very much, JD. This video will also be recorded, and it will be on our, and please feel free to pass it on to colleagues as well, even watch it together in your facility, so that we can actually start. This is the kind of presentation as well that really saves lives. So thanks very much, JD. And I don't know if you can see on your side, I have made a 5th poll for feedback, but I can't seem to access it on my side. You just want to check in your poll if there's the feedback question appears. Maybe because I've added it later.
Yes, there it is. It should be showing. I'm not sure if people can see it.
I can't see when you launch. I'm blind.
Yes, people are answering.
Okay, cool. So thank you very much, everybody. Please just answer that or put some of your information at least in the chat. I'll be on for a couple of minutes just doing last administration. Next week, we're moving on to emergency medicine, and we're having 2 emergency doctors from PE is going to be presenting on airway. And so we will be be dealing with some of these high stake situations that we find ourselves in. Thank you very much, everybody, and have a lovely night. I'll send out the resource pack for pediatrics either tomorrow night or on Wednesday. Cheers.
Cool. Thank you very much, everyone, for listening. I appreciate it.